Spine and thorax, part 1. So here are the surface features visible on the spine and thorax for the anterior view. Let's zoom. Okay, I'm just kidding. An umbilicus. Jugular notch. Why is it called the jugular notch? Because the jugular vein goes through there, right? All right, sternum, obviously your ribs. I feel like this is common sense, right? The edge of your rib cage is where it ends, right? You have your rectus abdominis, which is your washboard-looking muscles when you have a six-pack.
I do not have those.
I do, under my chunk. External obliques, umbilicus is your belly button. Your iliac crest, because we're going to learn about the muscles. Wow, the bones. The iliac crest is your top of your hip bone, per se. Inguinal ligament. So if I say the word inguinal, I'm talking about the groin area. We don't typically work in the inguinal area. It's an endangerment area, and it is a no-no zone. Now some people might need some work there, but you have to be very careful with your draping. Posterior view. So if you feel the back of where your neck and your shoulders, I guess, across here would start, you'll feel your neck change curves. That curve change is where your C7 and your T1 start, or C7 ends, T1 starts. So that's when the cervical spine curves into the thoracic. So that's what you're feeling. All right, here. The spinous processes, when you're looking at somebody where you can see their spine and the little bumps, like the malnourished or just the skinnier people, or if you see a dog or an animal that's emaciated or whatever, that's what you're seeing is your spinous process, the bumps. That's your dinosaur spikes, I call them. On the back, you have the posterior superior iliac sign. I'm going to call that PSIS. We're going to learn about that when we do the hips, on how to palpate ASIS and PSIS. The sacrum, that's right above the butt crack. Your tailbone is in that area. We'll call that the tailbone, right? When you hit your tailbone, it's your sacrum. It's your coccyx, technically, but in the sacrum area. Here we remember the border of the scapula, that medial border, right up to the outside or the lateral side of all your spines is a group of muscles that we are going to refer to as the erector group. These muscles keep you upright, keep you erect. You got your 12th rib kind of down in here, and your iliac crest is that top of, I call it the top of the heart, but the top of your hip bone on the back. Let's talk about bones, baby. I'm going to go here first. So your spine consists of the cervical vertebrae, thoracic vertebrae, burgers, I wish, lumbar vertebrae, and then we have our sacrum. But you have 7 cervical vertebrae, 7 vertebrae in your neck. You have 12 in your thoracic or your upper back. Once you get to the end of the ribs, that's when your lumbar, so you're changing the shape. You got your cervical, thoracic, lumbar, sacral. Remember the S curve that's natural when you don't have scoliosis. And then you have your lumbar. If you can't remember how many each, at least remember cervical has 7. If you add cervical and lumbar, the two curves that are together, the lordotic curves, it means 12. So the top and the bottom is the same amount that the middle is. If that helps at all. Yes. Let me zoom here. So this is obviously posterior view, because you can see the spine of the scapula and the spinous processes of the vertebrae. So this is the back view. If you're looking at somebody this way and you see the sternum and not the spinous process, we're looking at anterior. So here it goes over all different kinds of joints. Sternomandibular joint, sternocostal. If you see the word cost or coast or whatever, it's going to be ribs we're talking about. First rib, there is a muscle in your neck when we learn neck muscles that runs underneath that clavicle and connects on the first and the second rib. We'll learn about that. All right, so you have your sternum, right? Manubrium is on the top. You got your whole sternum, and then we go down to the tip is the xiphoid process. In between all your vertebrae are something called your intervertebral discs. That means in between vertebrae, they're the discs. We just call them discs for short. You guys may have heard about sacroiliac joint or your SI joint. When they say, oh, my SI joint is out. That's what we're talking about here. This is where your sacrum, this bone here, articulates or connects to your iliac crest or your ilium, which is part of your hip bone, your pelvic bone. So look at these here. I have your ribs. 1 through 7 is considered your true ribs. And I'm going to explain this in a second. I think we actually have a slide that does the ribs. Yeah. So true ribs, 1 through 7. False ribs, 8 through 12. Floating ribs, 11 and 12. So what I mean by this is true ribs. The first 7 ribs connect all the way around from sternum basically to spine. So look here. It articulates directly with the spine, and then it articulates directly with the sternum. You are going to have some cartilage connecting it to the sternum, right? So that's 1 through 7. False ribs. We're going to show you, see how these ribs look a little different down here? So they're not really connecting straight to the sternum. So those are called false ribs. So you have some connective tissue or more cartilage kind of giving that structure. Your floating ribs don't really connect at all. Those are the ones that you can easily break or puncture. When they puncture, they go into your lungs. That's fun. Or maybe they might puncture an organ. So we need to be careful with the floating ribs, which I'm going to zoom in here. Are these bottom ones just floating into space, kind of? Oops. Let's talk again about the cervical spine. So we're going to talk about the shapes a little bit of the cervical vertebrae. You guys are going to go probably more in detail in A&P with this. The main things I want you to know is what a spinous process is and what a transverse process is. So your spinous process, again, like I'm going to keep telling you guys, is the little dinosaur humps. Your transverse is going to be like your airplane wings on your vertebrae. The reason why you need to know this is because you have certain muscles in your back that connect to those transverse processes that allow you to laterally flex the spine. All right, let's zoom. This is C1. So this is your very first vertebrae. There's some chiropractors that do C1 only adjustments, and I think it's crazy. But C1 is also called your atlas. So you have your atlas, which is C1, your axis, which is C2. And all of them are shaped a little bit different. For funsies, we're going to look at this. Now, the atlas doesn't have very long transverse processes. If you see the word foramen, that means a hole. Okay? So, there you go. Here's your foramen. You have your lamina, which is this section here. And this is your vertebral foramen. The reason why we need holes is so that you can have nerves and such and structures pass through the holes without them getting pinched. So that's the main reason. Sometimes this area gets not clouded but compressed and smaller, that lamina. So I think that's called a laminectomy, where they go in and shave that out, right? So that you have more space for your spinal nerves to go through without you getting a pinched nerve. No, it's a pretty common procedure, and recovery is not terrible. I've not had it. Huh?
They go through the front.
Yeah.
That's the scary part.
The front. A lot of times they front. And then a lot of people get L4, L5 injured, and they'll have they call it back surgery. That's what they're talking about. Back surgery is surgery on the vertebrae of somewhere. All right. And then you have your facets. Your facets are where the other vertebrae will kind of sit in, okay? So that's our fun little picture of the atlas. Onto the axis. So all the vertebrae are kind of shaped a little bit different. These two in general are very different compared to the rest of the spine. And you'll see that certain parts of the spine, as it goes down, certain vertebrae are going to be thicker in certain areas to allow for more weight bearing and whatnot. And some might have more range of motion than others, depending on the shape of the spinous process and any facets. Here's the axis, so number 2. Now we have a spinous process showing. The reason why the other one doesn't is because it's like, I'm going to show you a picture. Can I pause this? Of my skeleton and the C1 and C2. All right, where are we at here? All right, so this is a C2 axis that is obviously going to look different, like I showed you on the skeleton, than the atlas. Now we're having a more pronounced spinous process. We're still not having huge transverse processes, but we're getting there, right? Alrighty. But this section here, again, is where all the nerves in the spine are going to be running through. All right, most of the C3 through 7 are going to be similar shape. They're just changing a little bit as they progress. But you have an even longer spinous process, yes. And now we're seeing that the foramen is, I lost my train of thought, is getting a little bit smaller. Boom, baby, boom. Now, thoracic is way different. So now your spinous, I'm going to bounce back. See how the spinous process over here is almost sticking straight out in a way? As we go into the thoracic vertebrae, it's going to kind of drop down a little bit so that they overlap on each other. Nicely stacked like Legos. So you'll have your body, which is the big chunk between the vertebrae, yes. Your transverse process, which is the wings, and your spinous process, which is the spikes on the back. Lumbar, I'm going to go back one more so you can see. The body here in the spinous process going down. And this guy's got a big chunk of spiny process and a nice big body. So they're all a little different. This has a little bit of a smaller foramen as well, which is probably why people tend to injure L4, L5 often. So the L stands for lumbar, if you haven't already caught on. C, cervical, T, thoracic, L, lumbar. All right, so I already showed you on the skeleton the difference between the true ribs, the false, and the floating. But for here, a little guide. Your true ribs, 1 through 7, are all attached directly to your sternum with connective tissue, or with cartilage, I'm sorry. You got a little bit of cartilage, right? False ribs attached to the sternum by the costal cartilage. So here's that costal, your rib, costal cartilage, and it all connects as one and then goes to the sternum. The floating don't attach to sternum at all. They're just floating around, waiting to be broken. Since I already showed you that, I'll move on here. Right. So the sternum has different parts that are labeled as well. You have your jugular notch, which is at the very top where you see that little divot on people, right? Also, that'd be a good spot to poke and have someone start coughing for fun. The manubrium, which is that top section of the sternum. You have your body, and that little fingerling on the bottom is your xiphoid process. So the body of the sternum is where the ribs tend to articulate. Boop, 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 boop. Let's look at some ribs a little bit closer. First rib and other rib, they say. So you're going to have the vertebral end, which means it connects to the vertebrae on the back of the spine, right? And your sternal end, which connects onto the sternum. So that vertebral end is where we call what we call the head. And then you have the neck. There's tubercles too. Remember, tubercles are usually where things attach to. And then you have right underneath something called the subclavian groove. So there's a tiny little muscle called the subclavian that helps and assists with breathing a little bit. That's right underneath the sternum. Not sternum, sorry. The clavicle. Thank you. All right, here's those curves. So humans do weird things with vocabulary, and they'll call an exaggerated curve of the thoracic kyphosis, but technically we all have kyphosis. We all have that curve. But if you see the term kyphosis, like someone says, I have kyphosis, or lordosis, they're talking about an exaggeration in that curve that we normally would have. So this is what the curve is like. I have the green curves that are your lordosis curves, and your orange curves, which are the kyphosis, or your kyphotic curves. They alternate. So if you can't remember what one does, just always remember lumbar L is lordosis, and then you can by cross or by a process of elimination, it's surrounded by the kyphotic curves, and then your top one is cervical is also lordosis. So just something to help you guys remember the curves of the spine. Now some people are lacking curves, and then they start having issues. A lot of people, which I said the technic, are starting to get straightened cervical curves, so they are losing that lordosis in the neck, and it's causing all kinds of issues. A lot of headaches, vertigo issues can arise from the spine not having its natural curve, all kinds of issues, tension in neck muscles, weakness in neck muscles, and then you just start developing a heaviness with your head. I forgot what each inch or whatever, how much weight it causes, but basically if you're like an inch or two forward, it's I don't know, like an extra, like, what, 20, 30 pounds or something. It might be an inch per 10 pounds of head weight. And that's what the stress is going to be on your cervical spine, how it's pulling. So take care of your neck. There's a lot of things you can also do to fix that curve. PTs and chiropractors can steer you in the right direction. They also have things called posture pumps, which you lay on like this little device and you have a little pump and it inflates and then deflates. So it forces that movement of the spine to get you into that curve a little bit better. And there's exercises to help. Let's learn about some bony landmark trails. This is the midline range. So as you're palpating people, they consider the spinous processes, the feeling of the different palpating your spinous process, the midline range. So when you're working on somebody, that is your midline, right? Your spine, as long as they don't have scoliosis to the side, which is a side curvature, you will feel these straight down. So when you do practice on each other, feel for that and see if you can feel if they have a weird curve. Sometimes you can't tell. Sometimes it's very, very, very clear that they have scoliosis. Crossing paths. This is a fun diagram to kind of remember here. I actually have lines on the human to the left as well. So when kind of straight across where you have that lump changing, right, and the top of your shoulder, this is going to be the C7 base of the neck, where your neck starts meeting your thorax, we'll call it, or your trunk. T2 is kind of typically right above that superior angle of the scapula. So if you find somebody's top angle of the scapula and you just go straight across, you're supposedly, as long as they don't have an elevation or a depression of the shoulder, supposedly supposed to be at thoracic 2 vertebrae. At that inferior angle, the bottom pointy part of your scapula, is where T7 kind of sits. So your thoracic 7. That's also where your true ribs end. Okay? T12 is at the waist. So where your natural waist is, the waist isn't down here. Technically, your waist is up here. That is T12, the end of your ribs and your thorax, and then you have L starting. So at the end, where your ribs end, if you go straight across, you're about at T12. You can also kind of feel a little bit as it changes shape into a curve, and then you're like, okay, that's lumbar. Some people have very defined lumbar lordosis, like an exaggeration. That's the people who have the big backs, right? That is not just having a big booty. That is lordosis of the lumbar spine, which causes all kinds of other issues, musculoskeletal issues. All right, the top of the hip bones, that iliac crest, is where L4 is. Most people with low back injuries have issues in lumbar number 4 and lumbar number 5 vertebrae. So when I say L4, L5, I'm talking about that section towards the bottom, and that's usually where there is a herniated disc, a bulging disc, lamina that has restricted the nerves, and so on. It's a very, very weak point, and this is also why it's important to, when you lift heavy things, watch your body mechanics, and important for us to watch our body mechanics while massaging, because if we reach too far over, we're putting a lot of strain on our body. The nape lane. The nape lane, or your lamina groove, is the spot just lateral to your spinous process on your spine. So if you kind of feel your own neck, which is the easiest to feel, you feel the bump, which is your spinous process, And just off to the side of that, there is going to be a little tiny groove, and then you have thick muscle. So that groove that holds those erectors or that muscle, that's going to be your lamina groove. Do, 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 do. So your neck's too fat? It's fine. Palpate on a really skinny person. Palpate on your cat. The cat might be fat too. I don't know.
My cat's got a fat
My cat is, she's fatter in the winter and thins out in the summer because she has more exercise. I'm like, this is probably how they're supposed to be. All right, Buried Boulevard. Peace out, Home Slice. Okay, the Buried Boulevard. So this person's exploring the lumbar vertebrae here. I don't even know what I'm looking at this picture. So, okay.
Spinous process.
SP means spinous process, and this is transverse process. So this person is kind of putting their hand over it, and they can, feel all of them, supposedly. All right, so these are the erectors. So see how you have this lamina groove? This is like the perfect area for a little muscle strap, which is the tenderloin, to fit into nicely. Tenderloin. Steak. Here we go. So this person is palpating, this is what I would call the lamina groove. So they're palpating between the spinous process and the transverse process for palpating all these erector muscles. So that's Buried Boulevard. Cool, man. The breastbone ridge. Now, I don't advise that we're all palpating each other's breastbones because, if you have somebody who's comfortable, you can, but you can do this yourself and palpate your own breastbone and, feel things. Explore and palpate. So the manubrium, which is superior, articulates with clavicles 1 and 2, or with the clavicles and the first and the second rib. Up here, right? Then you have your sternum, which is the whole body. You can do sternal work if the client is okay. It's also very, very tender because you're palpating basically bone where things attach, and it's a very tender area. So if your client is not comfortable with you doing this, just try it at home or a loved one and try to kind of rock back and forth and feel the sternum. It's really tender when you touch it. The xiphoid process is right where it all ends, okay? I feel like that's a lot harder to palpate, and it's really uncomfortable because your stomach is kind of right under there, and it feels like it made me nauseous doing that.
You can also break that when you're going to CPR.
Oh, yes, you can. That's uncomfortable. You could break the whole sternum. Ooh. All right, so the importance for the xiphoid process, which is the inferior part of this, is it's the attachment point for the rectus sheath. So your abdominal muscles, you're going to have something called the rectus sheath that connects all up here. You have a lot of connective tissue in the back, the low back, and the abdominal muscles that have to connect to the ribs and such. The bumpy road. These are dumb. So the bumpy road is palpating in between the rib cages. We're not going to just be palpating the front of people's breasts, okay? You can do rib work on the back. I do remember my raking. So that's what we're doing is we're trying to get our fingertips in between those ribs to get to those intercostal muscles, those muscles in between the ribs. So that's what is going on in this picture. Don't know what's going on. Oh, she's palpating that first rib. Whatevs. Body storming labeling worksheet. Okay, who cares? So that's the quick Bridget version of the anatomy of the thorax. Well, we ain't done, girlfriend. I'm a slave driver. The muscles of the spine of the thorax. We're going to go over a couple muscles. You guys are going to learn how to palpate and identify them and whatnot. So the muscles that move the vertebral column and the ribs in the thorax. So we're going to talk about those muscles that cause movement, cause the spine to actually move. Let's go. So this also includes the posterior neck because it's part of the spine. Learning how to palpate and work these posterior neck muscles is vital to being an awesome massage therapist. Ask my clients. Just kidding. No, actually, I'm known for my neck work. I have a passion in my neck work, and I love it. I can spend 45 minutes just on your neck and shoulders with you face up.
One of my students was real excited when she found out you were my instructor.
I wonder who it is.
Amy Converse.
Okay. Yeah. Awesome. That's right.
Yeah.
I guess you don't have a HIPAA violation with yoga.
No.
Okay.
We don't understand.
We don't know. You guys don't. You're not from Cambridgeshire. That's what the. That's what Siri says sometimes, or Cambridgeshire or something like that. Okay, so we have a lot of layers of the neck, and please don't ask me which ones are superficial, which are deep, because there's too many. But we're going to be talking about posterior neck muscles in a little bit of detail. I don't know when. It's coming up here soon. So the main thing is your trapezius. So see how these are all cut? The trapezius is the outermost layer, obviously, because it's a big, it's a trapezoid, but we'll say it's shaped like this, kind of, right? Basically like this. So that connects at the base of your skull, that neutral line. And then we're going to be talking about capituses. So you have your splenius capitis, your semispinalis capitis, your longissimus capitis. If you see the word cap, we're talking about it connecting onto your skull. So that's all you need to know right now. And then you have your cervicis. So if you see the splenius cervicis and the splenius capitis, the capitis is on your skull. Your cervicis connects on your cervical spine. So that's the difference between the two. But you see all these muscles just lining the, just kind of lining the neck. There's a lot. And then you have these little bad boys over here called the rotatores. You can call them rotators if you want. The reason why these are rotators is because of the shape. They are at an angle just like your rhomboids in your back. So they rotate the spine. You have rotators all the way down your spine, which gives you the movement to do this. So when you say rotatories and I say rotators, that's what I'm talking about. My teacher called them the rotators. Through the years, the words are changed. I think SCM was changed. I can't remember. Sternocleidomastoideus is what it was, and now it's sternocleidomastoid. Now that's something else. I don't know. Then we have more little rotators called the multifidi. But they're all going to be rotating the spine. Fun stuff. This is the cross section of the neck. This does not look like a neck, by the way. Looks like I'm... Oh, God. I'm trying to zoom here. I don't like these pictures. I look at it, I'm like, I don't know what's going on. But in this in this picture, this is your trapezius. What section is it? It's crossing here. Posterior view. I'm looking up.
It says if you had an MRI. So like,
This is what we're looking at. So here's your traps connecting at your skull, right? And then here are your more deeper muscles. This is some crazy stuff. But yeah, see how there's a lot of layers? This is why we're not just superficially doing relaxation massage when we're addressing the neck, because we need to get to all of those deep layers. That's what a deep tissue massage technically is. It's not, again, I'll reiterate, it's not all the pressure we can summon. It's just enough pressure to get to those deeper layers. So you're going to have to, have a firmness when doing this. Don't be afraid to massage the neck. I know there's endangerment. Your anterior and their posterior triangle, but you're still allowed to work the muscles. Okay? Cross section of, I don't like these pictures. We're going to move on, but just zoom here. This is the thorax or your thoracic region. Crazy. Here's your heart. Looks crazy. And your lungs. Lumbar. That's your turd tube.
I've never heard that.
I just made it up. You're welcome.
Great.
Yeah, psoas. I can't wait to show you guys psoas. It should be on the NBLEX. I need to be part of that board. Let's go over actions real quick on what the spine can do. And we're talking about the whole spine, minus the sacrum. So lumbar, thoracic, cervical spine. So your spine can flex. And remember, when everything flexes forward, we're flexing. Yeah, flexing in the fetal position, right? Extension is bringing it back up. So when you're doing a sit-up, you're flexing and then dropping back down into extension. When you're standing up and touching your toes, you're flexing and then bringing it back up for extension. So those two motions happen on the posterior and the anterior side. Now we have rotation. All right, this is lateral rotation. All right, I mean, you can't really medially rotate, so rotation, I think, is just a general term. A lot of your rotators are either going to be in the abdominal region or along your spine. Remember all those tiny, tiny little rotators in the multifidi that I talked about, those tiny little guys that are at an angle? So those are going to be your rotators. The spine also does lateral flexion. So it flexes forward and it also laterally flexes. A lot of us have very limited range of motion in lateral flexion, and we all need to stretch more. Right? So tons of muscles are involved with lateral flexion. And we'll go over those. All right, you do have a fun little thing called the diaphragm. The diaphragm helps you to force air in and out. Breathe. Inhale the good stuff. Exhale the bad stuff. So, you have your flexion, extension, rotation, lateral flexion. Now, this is coming from the ribs now. Your vertebrae is not like stretching out to do this. So you have your ribs that expand when you are breathing in. Just think you're breathing in and it's allowing room for like a balloon, right? I feel like this is common sense. And then it depresses when the air comes out. So here's a picture of what happens with the diaphragm. When we are breathing in and filling up the space, that diaphragm has to kind of flatten out so that it has, pretend it's the cork for the balloon. So it's got to flatten out. It will actually kind of contract like this to push it all back out. So imagine that is just somebody's fist pushing all the air out of your lungs. So when the diaphragm, actually I have it backwards, when it contracts, it expands, and when it relaxes, the air is forced out, so it kind of just collapses into there, right? So not only does your diaphragm assist in breathing, your intercostal muscles, all those muscles between your ribs, kind of assist in breathing. So we need those to function well. And sometimes people who have chronic diseases like respiratory diseases or sicknesses will have scarring, and maybe those muscles are so tight. You might actually have to do some diaphragm work or intercostal work to kind of free up some of those muscles so that they can breathe a little bit easier. I've done a diaphragm release only a few times, but I can teach you guys how to do that. It's not comfortable. You have to like wrap your fingers under the ribs in the front. Okay, dokie. So all these muscles, surprisingly, assist with breathing. They don't only just move like the scalenes, sternocleidomastoids, serratus, pecs. They also help with breathing.
90% of our population breathes.
Yeah, when you breathe correctly, you're supposed to, they say, fill up the belly. It's not really filling up the belly, but when you go, the belly should raise before the chest.
Your shoulders should not be in your ears.
No, not like this. We're not doing that.
That's how people breathe.
That's how people breathe. Y'all need to calm down and breathe better.
And if you need to practice breathing, lay down.
Yeah, so that
Because you can't really move your shoulders.
and then your shoulders are pulling back.
And you really can get that, like, focus.
We're gonna have breathing meditation with Hope.
Okay.
We should. And then have spa day afterwards. All right, group 1. I may have stopped it after this. Yeah. The erector spinae group and the transverso spinalis group. We're going to talk about all those groups. If you can't remember, just call them the erectors, right? All right, so this erector group consists of something called the erector spinalis, the erector longissimus, and the erector intercostalis. I'm going to zoom to show you the difference. Spinalis is closest to the spine, right? We're going to skip longissimus and go straight to iliocostalis. This attaches more medial onto the ribs. Lateral, just kidding. Between spinalis and intercostalis is your longissimus. So that's how you would remember the erector group. They're not all just along the spine, but they kind of go out a little to the ribs. It's also why it's important to do a lot of work when people are having back pain and issues like that along all those erectors. It feels really nice. That's why I do like the stretch, and I'll go up my elbow, or I'll rock and do like cross fiber all the way up the spine. It feels really nice and loosens those erector groups. What the heck do they do? Unilaterally, this is fun. They don't just erect. So if one side contracts, you're going into a lateral flexion. If both sides contract, that's when they decide to bring you back up to a neutral, yeah. So the extension of the vertebrae. They originate on something called the common tendon. So this is fascia that's on the thoracic and the lumbar region. And it kind of just all kind of connects into there. Then it attaches to the posterior surface of the sacrum. So all this white, remember I said that the back and the abdominals have a lot of connective tissue? That's what all this is. So this is what your tendinous material would be for these big back muscles. So this is the thoracocolumbar fascia. Alrighty. And then, where am I at? So it connects there onto the iliac crest. It also connects on all those spinous processes. So they are pulling the spine, and that's why we're able to do this movement. So it starts there and inserts onto transverse processes. We have a mastoid process here. That's that little spot on their head. So it kind of branches off and connects onto different ribs and different spots of the body to allow for all that movement. There are going to be erectors that go along all the major parts of your spine, your cervical spine, your thoracic, and so on. All right. So this is called the spinalis. So that first picture where it had the cervical spinalis, like stuff like that. So it originates on your spinous process. Again, these are all erectors, remember. Originates on the spinous process, and then inserts onto more spinous processes. So this is what it looks like. So this one starts here and then connects to another one. So it's kind of forming a bridge to different parts of the spine. Spinalis. So the name tells you that its main attachments is spine. So spinalis cervicis, spine to spine, spinalis thoracis, spine to spine. And here's a fun picture of them all meaty so you can kind of see what it looks like. But again, see how it just kind of hangs out along that lamina groove? Lots of muscles hang out here. Lots of muscles. I think we're stopping after the erectors. All right, here's the longissimus. So you had the spinalis. Now there's the longissimus. This is all those three, but we're breaking them up now so you can see them individually. So that one was all hanging out on all the spinous processes. Well, this is just kind of off to the side now, see? And then you have your intercostalis, which is going to be more on the outside here. So there's three zones of erector muscles. So this originates on that common tendon in the transverse processes. So you had the spinous that connected on spine to spine, and this is common tendon and thoracic, or transverse, sorry, too many words. And then it inserts onto the transverse processes of the ribs. So here is a better picture. It's like a big muscle that has a bunch of attachment points. So it's kind of going in and out like a sewing stitch. To here, to here, to the rib, to here. See how it crisscrosses, attaches, right?
So we have it on both sides.
Both sides, not just one, not just your right side, or else you'd be constantly just.
I mean, I know that was a dumb question.
Yeah. So we have all these erectors on both sides, or else we would be walking sideways, and not erect at all. We just flopped
So
over.
if somebody has scoliosis, then one side.
One side is very tight, and then the other side is very stretched, is what's happening with the scoliosis people. All right, here's the erector iliocostalis. Again, it's on that common tendon. It attaches on the posterior surface of the rib. So now intercostalis means it's all rib. Here's another picture. Now, since you don't have ribs in your lumbar spine, this is transverse process, transverse process, transverse process. See? Boop, boop, boop. Once we get to rib, it just kind of connects like that. Pretty cool, if you ask me. Very cool. Oh, I thought I was stopping here. How many? We'll finish at the end of the transversospinalis group. So these are going to be the guys that are going to do a lot of rotations. All right. Multifunctional. So this is the multifidi. I didn't mean to say multifunctional, but it is. So it rotates because it's, at an angle here a little bit. But it also, unilaterally, it rotates one-sided. If both are going together, you're not going to get a rotation because the other side's keeping it straight. You're going to get an extension. See, multifidi and the rotatories tend to kind of have multiple uses. Originates on the multifidi, the sacrum and the transverse process of the lumbar through the cervical vertebrae. So I'll show this picture here. We're just kind of going, each one has its own section. See this? 1, 2. These aren't all connected like the erectors. So you have individual multifidi. Now these look exactly the same. I'm going to go back. Multifidi, rotatores. This is why we lump them all in the rotator group. Hope that makes sense. Again, the rotatores rotate and extend. And they also hang out and attach on that transverse process. Here's both. So one side, this multifidi is on the left here, his left, and our left. And the rotators are on this right. But see how they're kind of the same, per se? So again, extensors and rotators. Then we have the semispinalis capitis. Break it down, semispinalis capitis. It's on the spine and on the head. The only thing this one does is extend the vertebral column, so to get you into an extension of your head. So none of the rest of your body has to move. This is how you go back and forth into flexion extension. They start on the transverse process, and then they insert onto that inferior neutral line, so the occiput. So that's why I think it's really important for you guys to start off and do a lot of work at the occipital or that suboccipital region in the back of the head because of all the muscles that you're going to see that attach to that. All right, that's the end of part 1.